I just want to say hello and welcome to everyone for attending today's webinar, Cardiac Arrhythmia Recognition for Sleep Techs During Sleep Studies. We really appreciate you taking time out of your busy schedules to be with us today. My name is Rachel Bohr, and I'm Enso Data's Senior Marketing Director. All right, and now I'd like to introduce you to Kristina. Kristina Weaver is the Executive Director of Population Health and Care Navigation at Parrish Medical Center in Titusville, Florida. She began her healthcare career as a paramedic, working in open heart surgical suites, a level 2 trauma center, and the EMS field before transitioning into sleep technology, where she eventually became a sleep center manager. Kristina played a key role in launching one of the first hospital-based sleep navigator programs. She previously served as president of the Florida Association of Sleep Technologists and as a board member for the American Academy of Sleep Technologists. In her current role, she leads population health initiatives focused on enhancing care coordination and improving community health outcomes. And we are very excited and fortunate to have Kristina with us today to provide education on this critical topic. And so I will let you take it from here.
Thank you. Thank you all for joining. Very excited to hit a record number of registered and attending on a webinar like this. Cardiac arrhythmias are so incredibly important to make sure that we all understand to where we can really safeguard our patients. So I'm really excited to be here. Today we're going to go over looking at and trying to understand the sleep apnea and cardiac emergency prevalence, right? Why are we talking about arrhythmias? We really need to understand how often they actually occur and become confident in recognizing these arrhythmias. We're going to go through looking at different waveforms. Really, my goal is I hope that when you all leave this webinar, that you're not memorizing waveforms. I hope that you're really trying to think through the waveform itself and what's happening during that arrhythmia by becoming a little bit more aware of that waveform and what it means. What's the pathophysiology behind the heart and what's happening during those different arrhythmias. And then we'll lastly run through a couple different scenarios. So I first want to start off just kind of lining up a story. And those of you that might have heard me talk before, I give this story a lot during a lot of my presentations because one, I think it really highlights the importance of what we do. It also, especially in relation to what I'm talking about today, it lines up that relative talk about arrhythmias and what can happen within our lab and how we can really help save a lot of lives. So this picture that you're looking up here on the screen, this is somebody that came to our lab. He was 53 years old. He, about 2 a.m. was having apnea after apnea after apnea. And I saw this. I did his sleep study. I saw this during his sleep study. If you look closely at that EKG, that rhythm strip, that ECG, we see some patterns there where he's beating, and we see a 7-second sinus pause. That happened during his sleep study that was apnea related. He went through the 7-second sinus pause. He also went through multiple bouts of VTAC, little short runs of ETAC. So as a former paramedic, I would have been freaking out, turning my sirens on, thinking this guy's about ready to code. But as a sleep tech, panicked a little bit, but I immediately called our medical director and said, hey, it's apnea related. He's having some pretty severe emergent arrhythmias. What do you want me to do? And depending on your different lab policies, some labs say you see this, you're sending straight out. Our lab was following our medical director orders. Based on this, he was asymptomatic. I put him on CPAP. He had a couple little shorter runs of VTAC, but has never had one more sinus pause, cleared up his apneas. His original AHI was 53 and DSATs down into the 60s. By the end of the night, we got his AHI down to 6 and very minimal arrhythmias. As sleep techs, we treat the underlying cause of what we're seeing. We see it's apnea related. This man, I woke up and he was so mad that I put him on a CPAP. I thought I was going to wake him up and he was going to feel great. He went into some major, really cool REM rebounds, and his SATs came back up. I thought he was going to feel wonderful. He was mad because he didn't want to wear a CPAP. The only reason why he even came to the lab is because his wife was threatening to kick him out of the bedroom. So he left that sleep lab. We can't really tell him much, but the doctor called back with results and said, dude, you're a ticking time bomb for a heart attack. You have to do something. He refused. Now, this was about 15 years ago. There wasn't a lot of options. About a year later, after his sleep study, he went up to Michigan to go visit his sister during his sister's wedding. He was supposed to be walking his sister down the aisle, and he unfortunately passed away of a heart attack in his sleep. This bothers me for a couple reasons. One, if he would have gotten treatment, potentially this wouldn't have happened. Number two, gosh, I mean, again, it was preventable, but we could have showed him other options. This bothers me, though. This was my dad. I made the decision at that point, going from being a paramedic and in the open heart suites and running around in a trauma bay, I questioned what I did in sleep and what did I make the right move. Seeing what occurred made me realize that we as sleep techs can make so much of a bigger difference in saving so many lives. This was my dad that had an arrhythmia that was non-compliant to CPAP. Now we have other options. But as we go through these different arrhythmias, I really want you to become confident to know how to recognize arrhythmias and know when to call, when it's emergent, when maybe you don't have to freak out as much. But no, these are occurring in our lab, and we'll kind of go through a little bit more why. So sleep apnea, night after night, it causes this fight or flight response. You all know that. We know that as sleep technologists. As sleep technologists, we also know the ideal optimal state for our sleep is really supposed to be that rest and relax state. That's not happening for these sleep apnea patients. So it's that fight or flight response, no different from if you're playing a prank on your grandpa and you're startling him, right? If you're walking around the corner or somebody gets scared, it's that sudden rush of epinephrine, spikes the heart rate up, gives you that kind of gut feeling of like somebody startled you. For sleep apnea, this is happening night after night and multiple times during the night. No wonder we're going to have cardiac arrhythmias. No wonder sleep apnea leads to more cardiac events and COPD and pulmonary events. It's your body's in that constant stress state. There's many studies out there that show that your emergencies in sleep centers are only on the rise. So the most common emergencies that are happening in sleep centers are cardiac events and falls. There's a large study that looked at from 2005 to 2015, and it showed, the study was released in 2021, but it showed that emergencies in sleep centers rose by 30%. I want us to take a pause and just think about that for a moment. From 2005 to 2015, emergencies rose by 30%. That's when home studies weren't really super popular yet. And we had a lot of people come in through our lab that weren't as high acuity, but it still was a higher emergencies by 30%. If we were to look at another 10-year study from 2015 to 2020-25, where our really healthy patients are getting these home studies, and we're really seeing mostly only the really sick patients in our labs, I guarantee you that emergency is going to be even higher than that. Probably, I would guess close to 60%. We have patients that are coming through our labs with left ventricular devices, our new phrenic nerve and hypoglossal nerve stimulators, dialysis. We had a patient a couple weeks ago that came in with peritoneal dialysis machine. Our patients that are coming through our labs are even sicker, so we have to be prepared. Our patients with sleep apnea they're 3 times more likely to die of sudden cardiac death from midnight to 6 a.m. So what you're looking at on the screen here, you're looking at the blue bar being our sleep apnea patients, the red bar being no apnea patients from midnight to 6 a.m. That's not just at home, right, with this untreated sleep apnea. This is potentially that patient that's been coming, that hasn't gone to the sleep lab in 10 years, that knows that they need to, and now they're in your lab. In your lab, they are 3 times more likely to die of sudden cardiac death if you're seeing that obstructive sleep apnea on that patient. So understanding, again, those pre-warning signs will be critical to ideally catch this if we can. When we're looking at severe sleep apnea, there's several studies also out there that show severe sleep apnea is related and causes some higher troponin levels. So if you were to go into an ER and complain of chest pain and they're thinking that you might have a heart attack or the patient might be having a heart attack, one of the first things that they're going to do is measure troponin levels. Troponin levels is that measure that lab value that shows if there's cardiac damage or not. So our patients that have severe sleep apnea, they're suggesting these patients that have these slight uptick in troponin levels are having these low-grade kind of myocardial infarctions night after night, or low-grade heart attacks. I would kind of explain it too when you're thinking about like a TIA to a stroke. Your patient that's a TIA, they're coming in maybe with these symptoms, they're losing oxygen, there's some clot, something that's about to throw a clot, but it's not a full-blown stroke yet. These severe sleep apnea patients that are throwing these slightly uptick in troponin levels, that's your precursor that something is bound to happen unless something changes. Our patients that have sleep apnea, about 50% of them show nocturnal arrhythmias. We do see coming into our sleep lab about 43% of our patients have new arrhythmias. Then we're looking at, when we look at our PVCs in our patients, I'm sure many of you see those PVCs, and a lot of PVCs can be benign, but they also can be pending on saying something else might be coming, especially if they have severe obstructive sleep apnea. But we are seeing that they have patients with obstructive sleep apnea, about 66% of them have PVCs, so there's some electrical sensitivity there. Our patients with our low SAT, so especially your emergent SATs below 60%, we're seeing a huge risk of VTAC in those patients. We all know why, right? You're not getting that good oxygen to the heart that's allowing the heart to pump effectively. And then 59% of our pacemaker patients have sleep apnea. Now, I want to take a pause there for a moment as well. A lot of times, right, you may be the one identifying that new arrhythmia. You may be the one that suddenly that patient does go into this potential emergent arrhythmias. This is stating more than half of our pacemaker patients have sleep apnea. Some of them may be coming into your lab, again, without that pacemaker yet, right? And so learning these arrhythmias, just keep kind of honing back into that and being confident in them will help to allow you to get that patient treatment earlier, especially if they need that pacemaker. When these patients are coming into the lab, I just want to take a pause and really remind you, please do not trust the patient when you're asking them if they have different arrhythmias. Trust what the doctor tells you. Trust that H&P. I can't tell you how many times we've had patients come into our sleep lab, they're ready for their sleep study, we hook them up, and we see that they have AFib. And we go back out, we go into their room, we say, hey, do you have any history of any irregular heartbeat? And they say, oh, I think at one point I might have had AFib. I think I have AFib. Because is that what you're seeing? And you trust the patient. But what you later find out is that this patient no longer should have AFib. They were in sinus rhythm for the last 2 years, so they're not on those good blood thinners to protect that patient anymore. Maybe they got cardiac ablated, maybe it was paroxysmal AFib, but you can't trust that patient, right? We're not expecting you to be a pharmacist and ensure that the patient's on the right meds to check for that AFib. So trust only your H&P. If your H&P does not show AFib and your patient is coming into the lab and you see AFib, I would treat that per your policy as a new arrhythmia. You never ever want that patient to tell you they have AFib and them not be on that right blood thinner and then their stroke out in your lab. Predict based off that patient's H&B, really predict what potentially could occur that night. I'm not saying think of the worst case scenario and scare yourself every night of the worst case scenario, but predict to where you're always prepared. If your patient's coming in, as an example, with a seizure, you're going to predict potentially they could be at risk for more seizures, and you're going to protect them with that bed, right? You're going to put some side rails on, you're going to protect them, make sure there's bumper pads. Do the same for your patients when you're looking at their H&P. As the example is, we had a little while ago, we had a patient that came in with heart failure. Their heart failure was so severe, they had a very low ejection fraction. They had through the roof blood pressure issues. It was resistant hypertension on 4 different meds. This patient, I'm looking through their H&P and I'm thinking potentially, again, worst case scenario, but I know I need to be prepared. What if they sleep in the recliner? What am I going to do if they did code? Where's my AED? If I have to prop the door open for EMS, what does that look like, right? Always predict and make sure that you are confident and ready to where you don't freeze up. But your H&P can really tell you a lot of things. Listen to your patient. If your patient's telling you they have chest pain, but you're not seeing anything on the rhythm strips, listen to your patient. Likewise, if you see a rhythm that's not an emergent rhythm, maybe some frequent PVCs and the patient's feeling short of breath, listen to that patient first. You're always going to check your patient first. Ultimately, you are the eyes and ears for that patient. So become confident. If you don't know something, do more research to where you can be that advocate and, again, potentially really save a life. So I'm going to spend a moment to reorient about just looking at the cardiac conduction system and how it works, and that'll help us kind of go through explaining the different arrhythmias and looking through what we're actually looking at when we're looking at waveforms. So first, we're going to start looking at and just talk through the pump. So this conduction system really supplies the conduction to make the pump work. So you have the pump and the electrical side. On the pump here, you're going to have to move, the heart has to move 4 different chambers. So if you're looking up here on the screen, you have your right atrium, your left atrium, your right ventricle, and your left ventricle. This blue side is looking at deoxygenated blood, so it needs to send some blood out to get reoxygenated. Your red side is looking at oxygenated blood that it's ready to send out to the body. Your ventricles down here are always going to be, they're your largest chambers of your heart, and so you're always going to feel, this is where you feel your pulse. You're always going to have that larger push from your ventricles than your atriums because it has to travel out. It has to really push that blood outside of the heart. Now, in order for this pump to work, you have to have that good conduction system to contract and relax to where it can fill back up with blood. So we'll start looking at what I'm pointing up on the screen here is your SA node. So your SA node is your natural pacemaker for your heart. Your SA node, ideally, if it's coming from your natural pacemaker of your heart, you should see a rate of 60 to 100 beats per minute. Now your SA node, it's going to send off a signal to then allow your atriums to contract. It's then going to travel on down here to your secondary or AV node. So your AV node is really, and we'll talk a lot about it around heart blocks, but your AV node is that kind of gatekeeper. So your AV node, if your heart starts beating up too fast, ideally your AV node should be kind of trying to slow it down. Sometimes your AV node can slow it down too much. Sometimes it can speed it up. Sometimes your AV node can completely block. Again, it's that gatekeeper. But ideally, it should be allowing your SA node to travel right through your AV node to get then down to your Purkinje fibers. But again, it's that gatekeeper. So your Purkinje fibers are found in your ventricles. So we started at the SA node that created that atrium contraction, traveled down through the AV node, through that middle part, the gatekeeper of the heart here. And now while it was traveling through here, your atrium's filling back up with blood. And then it's finally coming down here to your Purkinje fibers and pumping out that ventricle, really doing that ventricular contraction. That ventricular contraction is then again what pushes the blood out through the heart. Now, if your SA node gives out and your AV node all of a sudden picks up, you're looking at a slower heart rate, right? Your SA node is that normal 60 to 100. Your AV node is 40 to 60 beats per minute. And then if that AV node kicks out, you're in probably a little bit of trouble here. Your ventricles are picking up for ventricular escape rhythms. And that's where you get into the 20 to 40 beats per minute. So let's kind of break each of these sections down to where we can kind of see the different arrhythmias that come from each of these different sections, and we can know how to respond to those. When we start going into arrhythmias, I do want to point out though, just stopping here for a moment, it is critically important to get this view of this heart, right? When you really don't want to just look at the top part of the heart or straight down. We want to have a three-dimensional view of this heart. Lead placement is critical. I've ran into several sleep tags where maybe they're, especially male techs, where they may be uncomfortable putting that third lead under that intercostal space. Please, if you feel uncomfortable, hook the patient up. If you don't have a policy already for it, hook the patient up and just start your camera on your sleep studies. Ask the patient, if it's a female patient and that's why you're nervous, ask the patient to put it down their shirt, and then you can go ahead and unsticky it and stick it to their left or their intercostal space. Please don't just look at the top part of your heart. Really look diagonal, okay? When we start looking at different arrhythmias, it is important to better understand the different measurements of what is a delay and what's not. So mostly we're going to be looking at, especially around heart blocks, looking at this large box. So when you're looking at, and again, I'll explain it a little bit in some later slides, when you're looking at the time delay, especially from your atrium traveling down to your ventricles, you're going to keep in mind we really don't want that delay to be longer than this big box. Now, you're not looking at a 12-lead EKG. You're looking at a sleep study where you're looking at these little boxes. So we don't expect you to get super granular with this. So that's why we're really going to primarily focus on that large box, and especially around your AV node and your heart blocks. So as I've kind of went through a little bit here, and we're going to talk in deeper detail about each wave, but your P wave is that from that SA node, right? So you can see up here that P wave. Let's think about this as we're traveling through the heart. So your P wave coming from that atrium where that SA node is, that's that positive deflection. Now it's taking time to go from that P wave down to the ventricles, but it has to travel down through that gatekeeper, right? That PR segment. So you have your P wave, it travels down to the ventricles, and wait, I have a really big QRS here. That is your ventricular contraction. So remember what I said, your ventricles are really strong. They should be. Your ventricles are going to have that hard pump because it has to pump out to your lungs and to your body. Once that QRS or ventricles contract, then you're looking at the ST segment. This is critically important. We'll go through on why to really look at this part and make sure it's even with your PR interval. But your ventriculars just contracted, and then you're looking at that ST segment, the time it takes for your ventricles to then repolarize or relax and fill back up to get ready for their next pump. So when we're looking first, let's talk about that P wave. So your P wave is, again, your SA node in the atrial depolarization. And so it's that contraction of contraction of your upper part of your heart chambers, right? Of your atrium. So your P wave, if you really picture this, right? contraction, it's sending now the signal to get down to what I just called your AV node. But your P wave should be very pretty. It shouldn't be crazy pointy. It shouldn't be quivery. Your P wave should be a nice smooth bump. Ideally should be upward. Your P wave is about, 0.08 to 0.10 seconds. So those tiny little boxes, as much as half a big box. Ideally, you should see one P wave for every QRS. Your P waves allows that atrial to contract and then push it down to the ventricles to then just start that cycle. So, and again, remember your P wave comes from your SA node. So the rate you should be looking at is 60 to 100 beats per minute if it's coming from this SA node for a good clean P wave. Traveling from your P wave now through that PR interval. So remember, coming from the top part of your heart, traveling down through that gatekeeper. This now really allows, it slows it down to do a couple different things. It allows the time to where your atrium can fill back up with blood. It needs to slow it down to where it doesn't go too fast, where it doesn't have enough time to fill back up with blood to do that good pump. Again, depolarization being contraction, so it's that time from that pump filling back up with blood to travel to those AV nodes. Ideally, from the time of your P wave crossing through this PR interval, it should not be longer than one big box. If you start getting longer than 0.20 seconds or longer than one big box, we want to start thinking about, do I have some sort of heart block? It could just be simply a first-degree heart block, and we'll talk about that. But ideally, really look at if something looks odd from your P wave to your PR interval crossing to that QRX, it looks a little long, print out that strip, measure it, or take your ruler. I know a lot of our sleep softwares, you have the little ruler. Take the ruler on your look back screen and measure that. Is it greater than 0.20 seconds? If it is, we're going to start to think some other patterns and start to look at the different waveforms. Again, your function of this is to allow that ventricular, your atrium and your ventricular ventricles to fill back up to allow that effective pump. If it's moving too fast, you're going to see this and not a full, good, hearty pump. Once you move from your SA node through to your gatekeeper, your PR interval, now you're really starting to look at your ventricles. So your QRS, that widest or that tallest spike, it should ideally be narrow. But this is the time, if it's an effective, good pump, it's quickly going out through those Purkinje fibers, is taking that electrical conduction system and really, really contracting those. Sometimes you might see a QRS that might be a little wide. So we oftentimes see patients with sleep apnea, as an example, where, we talked about the way that the blood moves, and you have that deoxygenated blood and the good oxygenated blood. When that should be oxygenated blood comes back through those, especially those ventricles, especially that left ventricle, it should be oxygenated. But what if the patients have sleep apnea? It's not. So a lot of times what we see with this ventricular depolarization and this QRS complex is our ventricles are trying, but it is fatigued. And so what happens is it still has a hard, strong pump, but it's getting stretched out and it's getting weaker and fatigued. And so a lot of times what we'll start to see is that QRS complex with our heart failure patients might start to get a little bit wider, especially in that left ventricle, because that's really the hardest ventricle that has to push it from our head to our toes. So it has to travel a lot farther. So ideally it should be pumping a lot harder. We really, really want to see this QRS complex nice and narrow to where we have that strong, good pump and not that weak pump. It's going to start giving out. A lot of times you'll hear the word ejection fraction. So that's your cardiac output. And especially these patients with a poorer cardiac output or that poorer ejection fraction, you'll start to see some of those become a little bit widened as well. So when you're looking at the QRS, you're looking at your Q, R, ST. Some of these, it's important, we'll talk about the PRs or the ST segment a little bit on this as well. But again, just key thing to remember here is this is your strong, heavy pump. If you see it start to become widen, if you start to see it becoming too fast, we're going to start to question what's going on. But ideally, if it's coming from that P wave, it should be a normal, again, 60 to 100 beats per minute within that QRS. So once our ventricle's just pumped, now there's some time that it takes for the ventricles to start filling back up with blood. This is called our ST segment. So our ventriculars just contracted, that depolarization, and now they need to repolarize. So repolarize being relax and fill back up to where it can get that next pump out. Ideally, your ST segment should be flat, and it should match what we call the isoelectric line. So if you're looking on the screen here, you see your P wave, your PR interval here, your big QRS ventricular contraction, and your ST segment right here. This ST segment should be right in line with your PR interval. This is called your isoelectric line, your baseline. If your isoelectric line on the ST segment is higher than your PR interval, let's say this line here is up here, we're potentially looking at a pending infarction, so maybe an AMI, a heart attack. If it's lower, sometimes there can be signs of ischemia, that ST depression. So we're looking at an elevated ST as signs as potentially AMI, a depressed ST, potentially some signs of your ischemic or even some digoxin toxicity, some different medication toxicity. Now, I'll tell you, if you start to see that and your patient's asymptomatic, don't freak out. Really, please go back to looking at your lead placement. Always talk to the patient first. If your patient's symptomatic even the least bit and you see something like that, I personally would play extra cautious and let's call the medical director. If it's telltale signs of true ST elevation, don't hesitate, especially if they're symptomatic. Call 911. But if you go into the patient's room and they're asymptomatic, they're not sweaty, they don't have chest pain, they don't have any sort of symptoms, go back to your rhythm, look at your lead placement. We've seen sometimes where patients, even especially women with large breasts, they can kind of roll over and it shifts the view of the heart a little bit here. Just make sure you have a good, clean lead placement. So as I was saying about the ST segment, we're looking at, again, this is a normal isoelectric line where it says ST segment, right? This here is showing ST depression. So you can see here the ST depression is that ST interval here is lower than the PR interval. Here, we definitely don't like to see these. This is your STEMI. This PQRS is higher than the PR interval. So really make sure that these are coming back to that isoelectric line. Sometimes you may see patients that are coming in and they don't look picture perfect like this, but you can see the morphology of that EKG rhythm or that ECG rhythm strip and what happens after a longer period of time. We've seen sometimes where patients come in and they have inverted T waves, or we see on a 12 lead, there's other signs in the different leads, and they had a heart attack 3 years ago. A lot of times you can still pick that up on these 12 lead EKGs. We can't necessarily pick that up on our smaller 2 or 3 lead EKGs, but definitely making sure that we're looking at that isoelectric line. Now the last waveform here is looking at that T wave. So this is your ventricular repolarization. Again, your ventricles are relaxing, right? They're relaxing after that heavy, good QRS contraction. They're relaxing and they're really starting to fill back up with blood to get you prepared for the next cycle. The T wave ideally should be upward. Sometimes if it's inverted, sometimes if it's tall and peaked, that could be different signs of different electrolyte imbalances, could be a sign of a past MI, different ischemic issues. but ideally it should look a little bit larger than your P wave, but be nice and positive and a smooth, nice, positive, repolarized rhythm look. This is the recovery phase for the heart. And so when you're taking your patient's blood pressure, you're taking your systolic and diastolic, this is that diastolic number. What does the heart look like at rest? This is when you're taking the blood pressure, one of the most important is that bottom part of that number, because if the patient's blood pressure, let's say, is 101 on that diastolic, that bottom number, the heart's not relaxing. It's going to become fatigued. It's going to potentially lead to heart failure. And that's where, again, you start getting into the widened QRS. You're starting to look at the ventriculars, just getting not an effective pump. You're really looking at them slowing down and getting very fatigued. So where do we start? About to start jumping into some different rhythm strips. I want you to really think through, when we're jumping into these rhythm strips, really think through, where is it coming from? Okay, is it coming from your SA node, your AV node, or your ventricles? So we're looking for the rate, right? Your SA node, 60 to 100 beats a minute. That's your first telltale sign. Okay, I'm probably going to be in my SA node. Is the rhythm normal? Do you see P waves? Is your PR interval less than one big box or 5 mini boxes? Is your QRS present, upright, and tight? So there's going to be a pop quiz after this one here. So when we're looking at first your atrial arrhythmias, let's talk through each one, and then we're gonna do a poll to where we can start kind of pop quizzing you here to see if we're getting where we need to go. So your sinus tachycardia, what should your rhythm be? Shouldn't be more than 100, right? And so, but is your sinus tachycardia, it's coming from sinus, SA node. So I should see a P wave. Sinus tachycardia, I should still see that PR interval be less than 0.20, less than one big box. It's probably going to be smaller than that because it's moving pretty fast. I should see a tight and upright QRS, and I should still see my ventricular repolarization. Now, sometimes if the heart's moving too fast, some of those can get hidden a little bit there, but you're really looking at, it's just extra fast here, right? But it's still coming from that SA node where that P wave is present. Your sinus bradycardia, exactly the opposite, but we're still coming from that SA node. Now, I will tell you with sinus bradycardia, you're going to see some potential bradycardia, so that rate be below 60, be below 50, 40 when they're sleeping. But I'll tell you, so I'm a runner. I love to jog. I've done a couple triathlons. I remember going through a sleep study myself years ago, and this was years ago, and one of my techs freaked out on me. At the time, I was training for a half marathon, and my heart rate was 35. Probably would be freaking out a little bit too, but listen to your patient's history, okay? So you can still have slower rhythms in really, really healthy patients. Sometimes also some beta blockers can slow that heart rate down. But really, when you're looking at sinus bradycardia, you're going to see that slower rate. You're going to see a present P wave because it's coming from that SA node, sinus SA node. And you're going to see a normal PR interval, and you're still going to see pretty regular rhythm, right? Your premature atrial contraction. So your premature atrial contraction, that's literally exactly what it sounds. Premature, SA node fired. So I'm still pretty regular, except I all of a sudden have this premature atrial contraction, but I'm still going to see a upright and tight QRS with that. I'm still going to see my T wave. Supraventricular contraction, this is extra fast, right? Now, a patient cannot hold this rhythm. So when we're looking at sinus tachycardia, it's moving fast, but you can still have time to fill back up with blood. It's going to start getting tired, but you can still fill up with blood. Your supraventricular tachycardia, you have no time to really, really good fill back up with blood. So supraventricular tachycardia is greater than that 140 heart rate and moving pretty fast, to where this could be a potentially deadly rhythm. Supraventricular tachycardia can come from different electrolyte imbalances, can come from different rhythm conduction concerns, many different issues, but this is not a rhythm that you want to ignore. Your AFib, your atrial fib, probably one of the most common ones that we see here, but I want to highlight out, this is still technically coming from your SA node, but it's coming from multiple fires, right? So it's just quivering up here, and eventually it's letting them through. And so you're going to see that irregularly rhythm. So it's not going to be regular, but your atrium is going to be quivering up here. And this is one of the things when I pointed out about the H&P, we want to make sure that that you trust that H&P and that the patient is properly medicated for this AFib, because what happens here is the blood starts to coagulate here. And if you're not on the proper blood thinners, you're not on the proper medications, it can coagulate here and start to eventually, once it goes through, maybe let a clot through. Could throw that stroke, pulmonary embolism, DVT. So AFib, it can be very well controlled with medications. You can manage the risk with it, but if this is a new rhythm for the patient, I definitely would not ignore that, because that is a ticking time bomb and raises their risk for a stroke. Your A flutter. Something's happening weird here with your SA node. Something's starting to give out here. But your A flutter, you're still going to be pumping. It's not a quiver. You're still going to be pumping. And so your A flutter, you can have different conduction ratios. You may see 2 P waves that then result into a QRS. You may say 3-to-1, right? But you're still effectively pumping. It's just you have more P waves than that QRS, but you're still seeing the nice, pretty P waves. All right, ready for that poll?
So the question is, what rhythm strip represents sinus tachycardia?
So sinus tachycardia. Remember, we are fast, but there is still a little bit of time.
Okay, I'm going to launch the poll. Okay, so the results are the majority said D, 45%. Next was F, which was 40%, B, 9%, E, 4%, and A, 1%.
Okay, so this one was a little bit of a trick question, right? And so this is a tachyrhythm coming from the atrium. And so the correct answer was D. It's sinus tachycardia, not super crazy fast supraventricular tachycardia, which is F, but sinus tachycardia. So you still have some time for that atrium to fill back up, but it is faster than the 100 beats per minute. Was that the only poll for this one?
Billy, you have one more, and I can launch that one too. The next question was, what rhythm strip represents supraventricular tachycardia?
Oh, I just gave the answer to that. Sorry.
Oh, did you? Oh, we can skip it then if you want to go on.
Yeah. So remember, guys, what I said with the supraventricular tachycardia. This can be a potential. You could see syncope with these patients. You can see some chest pain, shortness of breath. That's not a rhythm to play with. So I'll just quickly list out before we go on to the AV node disorders. So your A, you see a P wave. It's nice and slow. You're looking at sinus bradycardia. So it's still coming from that AV or that SA node. You see the nice, pretty P waves. B, you're seeing a 3-to-1 ratio A flutter, right? So you see some pretty P waves in there. There's just too many of them, but it's not a quiver. It's still nice flutters to your QRS. Your C, this one can get a little tricky sometimes. Your premature atrial contraction. So you still see an SA node, still a narrow QRS. So it's not preventricular, it's preatrial. Your D, your sinus tach. Your E, that AFib, that quiver, where it's irregularly regular. So you really, when you're asking the question, is it regular? You don't see P waves, they're quivering. Really march out those QRSs, and you're going to see that they are irregular, but you're going to see some quivering again of that atrium. And then F being that last supra, crazy fast tachycardia. So now as we're looking at the different heart blocks, the heart blocks, remember, they're going through that AV node really looking at the gatekeeper process of the heart. And so with your heart blocks, we're looking at, I'm going to kind of explain through a couple different here, but your first degree heart block, it's getting delayed. So I'm not going to point out what rhythm it is yet. We're going to do a little bit of a poll here, but I'm going to start explaining it. So your first degree heart block, you're going to see a P wave, but remember it's going to be larger. That PR interval is going to be larger than 0.20. So it's going to be slightly slowed before it lets it go through to the ventricles. That gatekeeper is saying, wait, slow down. Your second degree block, Mobitz type 1, Winky block. You're looking at your P waves. You do have P waves. So P waves are trying to go through, but the gatekeeper is blocking them or not allowing them or slowing them down. So your second degree block, type 1, Winky block, is longer drop. Now I have Winky block. So you're going to see your second degree type 1 Winky block, your P wave, your PR interval, that PR interval is going to get longer and then longer before it suddenly drops. So remember I talked through, we want to measure the rate. We want to look at the rhythm. We want to look at your PR interval. Is it longer than a big box? You're going to find that this one is irregular because you're suddenly missing something. Your PR interval is going to get longer and longer before it drops. Second degree type 2, your Mobitz type 2. So your Mobitz type 2 is, think of, it's not a longer drop like your Winky block. Your PR interval will be equal on this one. So think of Mobitz type 2 equal, your PR interval is equal, but all of a sudden it's suddenly going to drop a QRS. It's going to drop that firing of the ventricles. This one here can be pretty deadly. It can lead to a third degree heart block. This second degree heart block, potentially your patient may need a pacemaker, they may have had a recent MI, but something's going on to where we need to worry about this one. Your first degree block, beta blockers could have caused that. Your patient, again, could be an athlete. They could have just naturally a lower sympathetic kind of relaxed. They're just naturally that relaxed person. Your first degree, unless the patient's symptomatic, should not be as worrisome. But if you see it, definitely notate it. Your second degree, you definitely want to notate it. If this is a new arrhythmia, per our policy, we still call our medical director. Something's going on here. But that second degree type 2, right? Type 2 PR interval is equal. We just suddenly drop a QRS. We really want to be calling somebody on this one. We want to be checking our patient for symptoms. Lastly, your third degree heart block, you're looking at your third degree heart block of suddenly your P waves and your QRS are not talking. There's a complete disassociation there. That one could be a pretty deadly rhythm. You will see a slower rate with these patients. All right, Rachel, do we want to do the poll? I know we're getting tight on time here too.
Yeah, we'll launch this one. Just have everybody answer really quickly. So the question is, what rhythm strip is second degree type 1 Winky block? So take a look. Let's launch.
Longer drop.
Get your answers in. We'll give everyone like 10 more seconds.
I'll give you a hint up on the screen while you're doing this. Looking at these PR intervals here.
All right.
Longer drop.
Okay, it looks like we have most of the votes that we're going to get, so I will share the results. It looks like we are 54% said B, as in boy, 24% A, 15% C, 8% D.
Okay, so your Winky block, longer drop. I want you all to take a close look at A and look at that P wave and look at the PR interval. It's short. Your P wave to your next PR interval gets a little bit longer, suddenly it drops. Versus B, this PR interval for each one of these is very equal. So equal B in type 2. You just suddenly lose a QRS. So your correct answer is A, longer drop, now I have winky Bach. B is second degree type 2 because that equal PR interval, it just suddenly drops a QRS. C is first degree heart block, you have longer than this little box. And D, there's no association between your QRS and your Ps. There's no association, they're not talking. And so this is a very slow, potentially fatal rhythm. All right, lastly, before we just get to just two scenarios here, we're gonna look at some ventricular rhythms here. So pre-ventricular beats, you're still coming from that SA node, but it's a pre-ventricular beat. We'll look at those. Accelerated idioventricular rhythm. And this one, there's a little trick with this one. You're looking at slow VTach, right? Your rate being 60 to 100, your idioventricular, your ventricular tachycardia. Again, these are all ventricular rhythms except for the PVCs. Now your SA node is given out. Something's occurring here. So ventricular tachycardia, if now the SA node is out, your ventricular tachycardia, you're going to have just fast ventricles trying to fire off. Your ventricular flutter, your ventricles are going with no SA node. They're trying. This is deadly. And VFib, you're looking at this. So when we're looking at these different rhythms, and I know we have a poll here too, but I wanted to just real quick just talk through again. I want you to look at C. C, this is the only one that is not a true ventricular rhythm. There's a pre-ventricular beat that's coming in there on a true foundation of an SA rhythm here. Now pay close attention to the rates too when you're looking at this. A, that ventricular VFib, you're not going to have no pumping, right? So let's kind of look through if we want to jump into the poll here. So this one, there's a little trick to this one. So you might see an answer in there that we didn't talk about.
All right, let's give it a few more seconds. All right, looks like we can probably end it. We're hitting 50%. Cool. All right, so we have 40% paced rhythm, 39% left bundle branch block, and 21% ventricular tachycardia.
So it's definitely not ventricular tachycardia because it's very fast, right? And so what we're really looking at, and this is where oftentimes we get paced rhythms mixed up with left ventricular bundle branch blocks, and we get idioventricular escape rhythms mixed up. Really, really look at your rate. So the correct answer when we're looking at D, this is a left bundle branch block, but this, because it's faster, it's not an escape ventricular rhythm, okay? But we know that it's normal, it's regular. Your A is looking at VFib, it's not pumping. B is asystole. Your C is that preventricular contraction. E being that fast ventricles, it's trying. One of the things I will say here is, as a paramedic, I have never ever gotten back asystole. I have gotten back these other rhythms because there's electrical activity for the AED to grab. Looking at heart blocks, and we don't have a poll here, but I want to present you a case just real quick as being one of the last scenarios here. So Mr. Edwards, he shows a Mobitz type 2, right? And so that's type 2. There's a PR interval that's nice and equal. Suddenly the QRS drops, and he has no history of arrhythmias. What do we do? Again, please, your type 2, your Mobitz type 2, and your third degree, these can be life-threatening. Please, any new arrhythmia, notify, follow your policy. But really always check that patient first. But type 2, it's equal. It suddenly drops. It is more dangerous than that longer drop, winky Bach. Last one here, I know I just said last one, sorry, I do think this one is really important here. So I want you to picture yourself, you're a tech working by yourself. Maybe you're not working by yourself. Maybe you have another tech, but you have a patient, Mrs. Jones, BMI of 48, so a little bit of a larger lady, sleeping in a recliner. And suddenly she does this. This is where I really, really please prep for your night. Think through these different scenarios, practice in your lab. We've practiced in our lab multiple times with this, where how would you get that large patient out of the recliner? How would you do compressions? What happens? So I hope you all learned more of the pathophysiology behind the different arrhythmias, to where you can become more confident in the different rhythms. But thank you all for joining today. All right, Rachel.
Thank you, Kristina. This was really an amazing presentation, and we really want to thank you for taking time to do this for us today. I guess before we close the webinar, Kristina, do you have anything else that you would like to share with the audience?
I would just say, if you're uneasy and you're not confident in those arrhythmias, please do more research, reflect back to this, but really don't memorize the arrhythmias. Try to understand the waveform and where they're coming from, and it's going to be much easier.